Georgetown University. He is the head of, for pediatric kidney transplant, and head of and director of kidney and pancreas transplant. So today he's going to talk to us, as you know, about a very interesting topic, and that's an update on pancreatic transplant and what we do here. Dr. Melancon? I'm going to start to put these down a little bit, and then maybe I'll have you put them down. Yeah, you're all set. Thank you. Appreciate it.
Hello. It's very much a pleasure for me to be here, because I really think that this is the most important, one of the most important things that we do is really actually speaking to people in the community. You know, I spend a lot of time speaking to medical professionals and whatnot, but I think we are most effective when we speak to actual patients, because you have to be advocates for yourselves and your families, and I really think that when you can get the information into your hands, you're able to do much more with it even than the health professionals. Now, it may seem curious to you that in a talk about pancreas transplant, I have a photograph there of a woman, and it says break free from dialysis. But it's very important that you understand that what hastens death in people with diabetes is really kidney disease more than anything. People can die from a variety of reasons, but diabetics really do not do well once they have kidney disease. So my discussion today really is going to focus on things that I'm very interested in. Obviously, pancreas transplantation, as well as kidney transplantation, but also disparities. And I have recently authored a paper that actually just came out that, and I'm going to show you some of that research. But the idea is to disseminate the information, and at the end we can have questions. But I'm going to go through the data as to why I think one of the things that's very important for people with diabetes is having a surgical option. Surgical option means not everyone is going to be a good candidate for a pancreas transplant or even a kidney pancreas transplant, but there is a segment of the diabetic population that this is going to be the best possible therapy. And that's what I'm going to focus in on today. Let's see if I can get this going. So we are going to talk about pancreas and islet transplant. And I'm going to start with a case report. This is a lady I saw in my clinic a few years ago. It's a 50-year-old white lady who had diabetes since the age of 8. She's 5 foot 8 inches tall, 130 pounds, and she was really in a good state of health. And what she was starting to develop after having lifelong diabetes was the fact that she was having these periods of hypoglycemic unawareness, which is very dangerous. So I told you that kidney disease is very dangerous for diabetics. Once you get to the point of autonomic dysfunction where you have hypoglycemic unawareness, that can be life-threatening as well. So she actually did not have a lot of the other problems that diabetics can have, including retinopathy and nephropathy. She did not have kidney disease, did not have cardiovascular disease. She did have a mild peripheral neuropathy, had never had surgery. She already had 2 healthy children. She had been married for 20 years. Physical examination was actually quite normal. Her C-peptide was very low, which is going to be very common in type 1 diabetics. Her hemoglobin A1C was actually pretty good. Not totally normal, but 6 to 7, as those of you who are diabetics know, that's pretty good. All right, and her creatinine was normal, absolutely normal, so she did not have kidney disease. And she was not taking any medicines other than her insulin. She did not want to go on an insulin pump, but she was very concerned about these hypoglycemic episodes. And it was for that reason that she was coming to see me, a transplant surgeon. So what were her options? Her options are to continue with insulin therapy like she was receiving, move on to an insulin pump, which she did not want, but we know it can be, insulin pumps can work very well. She could have a pancreas transplant, the whole organ pancreas transplant, or she could have an islet transplant, which remains experimental, but it is available. Okay, so I'm going to back up a little bit. So now, in 1993, there was this very big trial that was done, which has been updated since then, but this was a very significant thing in the history of the treatment of diabetes, because the diabetes control and complications trial basically showed that the better you control your glucose, the better you do. So that brought into us into the modern field of what we do for diabetes, which is to try to get the hemoglobin A1C in a normal range. And that's what insulin therapy is all about, pump therapy and whatnot. So it was really this trial that in a very scientific way, treating thousands upon thousands of patients, that this was well established. The American Diabetes Association, so I will tell you, the medical doctors that treat diabetes have been very circumspect of surgical treatment for diabetes for a long time. This tide has started to turn. In 2003, the American Diabetes Association actually, for the first time, came out and supported pancreas transplant in patients that would be appropriate surgical candidates, and patients that are not having optimal treatment of their diabetes with medicine, i.e. insulin. Here's the issue, here's the problem. The incidence of diabetes is increasing. This is, it's mostly, this is all diabetes, so this is mostly type 2 diabetes, but also type 1 diabetes. We think we have a pretty good handle on why type 2 diabetes has become pretty much epidemic in this country, or in the West, period. Obesity obviously is one of the big reasons, but type 1 diabetes is also increasing, and no one quite understands why type 1 diabetes is increasing as well. But the incidence of overall diabetes is increasing. And now, for end-stage renal disease, the #1 reason for a person in this country to have renal disease is because of diabetes. So now diabetes has become the most common reason that people will develop end-stage renal disease. Now, many of those patients, many of those diabetics also have hypertension, but the point is diabetes incidence is increasing, and its contribution to renal disease is also increasing. And as I've already alluded to, it is that population, people that have both renal disease and diabetes, that's the population we worry about the most, because they do particularly poorly on renal replacement therapy, hemodialysis or peritoneal dialysis. So this is a very important population to find and treat as soon as possible, because their lives are significantly shortened. Whenever I talk about transplant, I love to show this slide, the patron saints of transplantation, because this in Western literature, this was really the first instance where transplant is mentioned. And any of you who traveled to Europe and to many of the great museums there may have seen lithographs of this painting. There are lots of different variations, but basically Cosmas and Damien were two physicians. They were brothers, and they were very early followers of Christianity. And one of the things that they were associated with, the reason why they became saints, is that they were associated with a miracle, and the miracle was this transplantation of a limb from a recently departed Ethiopian to a Roman citizen who lost his leg from cancer, and this myth, or this well, depends how you look at it, myth versus miracle, was very, very popular in medieval times, and these paintings are all over Europe. And like I said, it's the first time that we talk about transplant in Western literature. When you receive a pancreas transplant, there are different ways to receive a pancreas transplant. The most common way is to receive a pancreas along with a kidney. And so a person that has diabetes, that's developed kidney disease, you can get a kidney and a pancreas at the same time. You can also receive a pancreas after you've had a prior transplant, like a kidney transplant, or you can receive a pancreas transplant alone. I will tell you the pancreas transplant alone is the most controversial because these patients obviously have not developed kidney disease, and their life expectancy would be pretty good even if they didn't receive a pancreas transplant. So what you're really trying to do is you're trying to prevent renal disease as well as all of the other side effects of diabetes. You can also receive an islet transplant, and again, islet transplantation, which is just receiving the cells that produce insulin inside the pancreas, is still experimental, although it is done with increased frequency. So diabetes actually represents one of the most attractive targets for cellular and regenerative therapy. As Dr. Solo mentioned, here, as well as many institutes around the country, are very focused on the idea of diabetic research. It seems relatively simple to have a cell that will generate insulin that can be placed in the body of a diabetic and eliminate the need for exogenous insulin. So there's a lot of interest in that, and there's a lot of funding going in that direction. And the problem, obviously, is that we've not been successful as of yet. But I do believe of the cellular therapies that are being constructed, that beta cell replacement is going to be a successful therapy within many of our lifetimes. So hopefully within the next decade or so, we will have some sort of beta cell replacement where we can actually replace the cells instead of having to replace the entire pancreas. So the ideal cure for type 1 diabetes is going to be a device or tissue that will reliably give insulin. One of the problems and one of the big advantages actually of pancreas transplant is that a pancreas does not just give you insulin. There are other hormones that are very important to keeping your glucose within normal limits, what we call euglycemia. Euglycemia is really what you are aiming for with an insulin pump or whatever. But those of you that have been on insulin a long period of time, you know that with time, often what will happen is the more and more insulin you take, the more likely you are to have these periods of dropping your blood glucose. And it's that roller coaster of high and low levels that can be very dangerous. So what we really strive for is euglycemia, keeping you in a normal glucose range, not being too low, not being too high. When you're high all the time, that's where all the complications come from that are associated with diabetes. When you drop low, that can be life-threatening. So euglycemia is what we shoot for, and that's the whole idea behind the pancreas transplant, because no form of insulin therapy for some patients, after a period of autonomic dysfunction, no form of insulin therapy is going to make you euglycemic. It can pull your sugar down, but it can't be the floor for you if you have autonomic dysfunction. So it's that euglycemia that we're really shooting for. So the history of pancreas transplant is, the first transplant was done in 1966 at the University of Minnesota, which is where I trained. And in the beginning, the outcomes were not very good. However, over time, they have improved. So a lot of the horror stories that people heard about pancreas transplant had to do with what was happening back in the early experience. Transplant as a field, even kidney transplant, the first transplant ever that was done successfully in humans is only in the 1950s. 1954 was the first kidney transplant. So the field of transplantation really is not it hasn't been around a long time. However, it was in the last few decades that outcomes have improved drastically, and that's why we have so many more patients coming forth to receive transplants today, and oftentimes we have long wait lists. luckily, pancreas transplant is one of the few organs where the wait